Okay, then the next one over here is NSTEMI. Okay, so in ACS, NSTEMI and unstable angina is on one side, and on the other side there is STEMI. To differentiate between the NSTEMI and unstable angina, in NSTEMI, the TROP would be positive. There will be the ST depression in unstable angina as well as in the NSTEMI, and the STEMI has the ST elevation. Now, what you do if a patient is coming to you with the NSTEMI, with typical chest pain and is having a ST depression? So you give the ACS protocol, okay, the ACS protocol that contains aspirin plus clopidogrel, 300 mg of the aspirin and 300 mg of the clopidogrel, basically 300 to 600 of the clopidogrel. Okay, and you need to give heparin as well. Okay, you can give unfractionated heparin or low molecular weight heparin and the fondaparinux or fondaparinux, either of them. But they give the fondaparinux in UK. Okay, but that keeps on changing. But if you're gonna have a scenario like that, you have to choose the aspirin, clopidogrel, and the heparin. Okay. So the patient is coming to you with the NSTEMI, you give the ACS protocol, okay, and then actually when you go for the angioplasty, this patient angiography and angioplasty, that's PCI, percutaneous intervention, you calculate a grace score. Okay, if it is low risk, okay, then you can delay the percutaneous intervention. But if it's intermediate or high, you need to do PCR within 72 hours. Okay, and the other therapy to a patient with ACS, that is a inhibitor, beta blocker, and the statin, that's gonna go like that. But if an NSTEMI, you do not go for thrombolysis. Okay, that's particularly a thing that's related to the STEMI. Okay, not the NSTEMI or unstable angina. You give the ACS protocol that contains like aspirin, clopidogrel, and heparin. Okay, those patients who have a low bleeding risk, you can give the ticagrelor instead of clopidogrel. But if the bleeding risk is high or the patient is already on some anticoagulants, then you need to choose the clopidogrel. And then you calculate the grace score. And if it's low risk, then you can delay the PCI to that patient. Okay, you can discharge the patient and you can call again. Okay, you can continue the medical treatment until unless there is a second episode or the patient is having again the chest pain, and that is not optimized by the medical therapy you are giving the patient. But in the patient who is having a grace score of intermediate or high risk grace, that's greater than 3, less than 3, that is 3 or less than 3, that is the low risk. Greater than 3, that's intermediate or high risk. So there you need to go for PCI within 72 hours, like within 3 days. Okay, and every patient of NSTEMI, STEMI, or unstable angina is gonna get dual antiplatelet as when you're gonna send the patient home. Dual antiplatelet, beta blockers, statins. Okay, and you have to give the nitrates as well if the patient is having the chest pain, or you can use the sublingual nitrates if there is an episode of chest pain. But dual antiplatelet, statins, and the beta blocker and the AC inhibitor, these things gonna go like that. So a 58 years old with acute chest pain radiating to the left arm features suggestive of ischemic heart disease, ECG is normal. What is the next step? If there's acute chest pain radiating to the left, 58 years old, and suggestive of ischemic heart disease, like the PAN, it's typical PAN, ECG is normal. What is the next step? The next step is to go for the troponin. Okay, if troponin is high, it could be NSTEMI, because 5% of the patients, okay, you are not going to find anything in the ECG, but still the ischemia is going on and the underlying ischemia. That's why whenever there's a typical chest pain and the risk factors there, and it's a typical chest pain, by typical chest pain, I mean that, okay, that if it's a chest pain, it's having a character that's, okay, there's a pressing going to the jaw or the arms, okay, and the diaphragm. That's one point. The second thing is it's aggravated by some exertion, and the third thing, it's relieved by nitrates. So if the 3 points are positive, what I have told you, that's a typical chest pain. If 2 are positive, that's atypical chest pain. And if 1 is positive only, that is likely to be a non-cardiac pain. So if the patient is coming to you with a typical chest pain, okay, you need to do, even if the ECG is fine, you need to go for the serial ECGs, okay, and serial tropi. Okay, so the best is even if the ECG is normal, maybe the trop, maybe it's positive, you need to consider that one. Okay, so you have to give aspirin plus clopidogrel and low molecular weight heparin. When a patient with the STEMI comes to you, okay, you need not to go for the troponin because ST elevation is there, chest pain is there. Okay, so what you do, you give the aspirin and the clopidogrel. Okay, and you need to go for primary PCI, that's percutaneous intervention. If that's not available, then you can go for thrombolysis, okay, with LT+. A 50-year-old man drinks 8 units of alcohol and 20 cigarettes a day, BMI of 27, cholesterol. The best advice for him is refer to smoke cessation clinic. He's smoking quite heavily. A 50-year-old guy with acute chest pain radiating to the left arm with the feature suggestive of ischemic heart disease. ECG shows ST elevation. Where comes the ST elevation and there's a PCI? Go for the PCI. Okay? Go for the PCI. No other option. If the PCI is not there, go for thrombolysis. That is with the LT players or tenective players, whatever is given over there. Okay, and yeah, you give the sublingual, that's a spray of GTN and the morphine, and you need to give the morphine IV, okay, not intramuscular, because you need to relieve the pain because cardiac pain is intense, it's severe, so you need to give that one IV. Now, if you look at the ECG, okay, you can see that there are ST elevation in V2, V3, V4, V5, V6, even up to the V6. So this is an anterior wall MI. Okay, you can see if it's all in all the leads from V1 to V6, that's extensive interior wall MI. Okay, and you need to go for PCI. If that's not in the option, what you're gonna do if you have found this ECG, okay, the first step you're gonna do, you're gonna give the aspirin, clopidogrel, and morphine, and then you need to go for the PCI if that's available. So complications of the MI. So in first day, it's within 24 hours, it's ventricular fibrillation, the failure. In 1 to 3 days, it comes the pericarditis. Do you remember from the last lecture? From 24 to 72 hours, it is acute pericarditis. And here, down comes the Dressler syndrome, 2 to 6 weeks. Dressler syndrome. Okay, within 1 to 2 weeks, there's a free wall rupture, cardiac tamponade, and papillary muscle rupture. So all kind of your ruptures that, okay, of the wall or the septum, they come in 1 to 2 weeks. Okay. And left ventricular pseudoaneurysm. Okay, if an aneurysm is formed, that patient is having a persistent ST elevations, even if you have done some intervention. That's why if there are persistent ST elevations, okay, and you have done PCI or you have thrombolyzed, one thing you think of that is pseudoaneurysm, but you need to remember that it doesn't develop like early. It's in 1 to 2 weeks, okay, not before that. And in 2 weeks, you know, it's a Dressler syndrome, true ventricular aneurysm, chronic heart failure. It's the same. Okay. So stable versus unstable angina. So in a stable angina, okay, the ECG would be normal. Okay, the patient is having a pain with exertion. That's a stable angina. And this unstable angina, he is having a pain during the rest. Okay, but any of the pain, okay, if the patient is having a stable angina, but now it is becoming more intense and becoming more frequent, okay, so it's turning into unstable angina now. In stable angina, ECG would be normal, okay, the ECG might show something only during the pain, if the patient is having a pain, okay, the pain is less than 20 minutes, okay, and this is not a part of ACS. ACS is unstemy, STEMI, unstable angina, and the STEMI. So in stable angina, you give antiplatelet, statin, beta blocker, ACE inhibitor, and GTN spray. Okay, when the patient is having the PAN. The unstable angina, okay, that is a more intense thing as compared to the stable angina. So patients having the symptoms at the rest as well. So PAN typically lasts more than 20 minutes. Okay, so ECG, you may have faced like T inversions, ST depressions. Okay, so whenever unstable angina, the patient's coming to you. Okay, you give, how you're going to differentiate? There will be ST depression, T inversion based on the trop. Okay, so trop will be negative in unstable angina, but there will be the ECG changes. However, in stable angina, there will not be any ECG changes until unless the patient is having a PAN, active PAN at that time. Okay. Now, troponin interpretation. Okay. Troponin I is specific to myocardium. When it's injured, it's released. Again, you're going to detect some level in your blood. So if the patient is coming to you with the symptoms and the onset is greater than 1 hour, by the way, the troponin, okay, it takes like 2 to 4 hours, okay, for the sufficient level to be built to be detected in your blood. If your patient's having a chest pain and it's NSTEMI and you are going to do within half an hour or 1 hour, trop may come as negative. But if the patient is like having a symptom greater than 3 hours and it's a normal trop, okay, unlikely ACS. If it's having the symptoms, onset is less than 3 normal trop, you need to repeat the trop. Okay, you need to repeat the trop because it itself takes like 2 to 4 hours to build up. If the patient's having symptoms less than 3 hours and trop is positive means it's ACS. You need to start the treatment. But if it's a typical chest pain, ECG changes are there, or if the ECG changes are not even there, say for example, that you have done the trop and chest pain was less than like 2 hours, okay, and it's negative, okay, you need to repeat the trop because it's going to take some time. Now, it's a cardiac pain that started 4 hours ago and normal troponin. What you're going to do? So normal troponin, if the ECG is fine, okay, it's normal ECG. If the ECG is having the changes, you need to go for the trop. Again, the ECG is fine, it's having a chest pain, but after 4 hours, the ECG is fine, trop is negative, it's unlikely ACS. So if the patient is having the pain started like 2 hours ago and the normal ECG, normal troponin, you need to repeat the troponin. You need to remember it takes like 2 to 4 hours, okay, to raise, sometimes 2 to 6 hours. In a few books, it's written like 2 to 6 hours. Now, again, the cardiac sounding chest pain, 2 hours ago, normal ECG, trop very high, you need to treat. Okay, it's typical chest pain, trop is positive, you need to treat. Okay, because ECG could be like normal in 5% of the patient. So again, the cardiac sounding chest pain, ECG shows STEMI. If the STEMI is there, you need not to go for the trop. Okay, just act immediately. Go for the PCA. If not available in 120 minutes, then go for the thrombolysis. Now comes a very important topic, that is pulmonary embolism. So a patient who is having cancer, a patient who is having surgery, or who has traveled by air, who is immobilized, coming to you, the scenario is going to be like that. A patient who is having on this combined oral contraceptive pills, so coming with the chest pain and the breathlessness, and there might be a DVT, okay, swelling of one, you need to look for pulmonary embolism. Okay, you need to think of pulmonary embolism. Risk factors are, as I have already told you, immobilization, okay, surgery, trauma, bedridden patients, cancer, oral contraceptive pills, okay. So the patient will be breathless, okay, and you need to look at these risk factors and you calculate the 2-level P-eval score, okay. What you're going to find in the ECG, in the most common, this is important. The most common finding in the ECG is what? Either it's S1Q3T3. No, it's not. It is sinus tachycardia. Okay, so you have to choose between the sinus tachycardia and S1Q3T3, you need to choose this one on the ECG, sinus tachycardia, okay, not the S1Q3T3, okay. Always choose sinus tachycardia. That is the most common finding, okay, and most common symptoms of patients coming, that is the breathlessness. Okay. So if the patient is, you're suspecting the pulmonary embolism in a patient, so you need to calculate the well score, okay, and if that falls under the criteria, you need to go for the CTPA. If it's not falling in the criteria, you need to go for the D dimers, okay, and if the D dimer is positive, you eventually have to go for the CTPA. In a patient who is having a high well score, okay, you need not to wait for giving the entire anticoagulant. Give the anticoagulant and send the patient for immediate CTPA. If the patient is having a low score, 2-level P well score, then get the D dimer. If they are positive, then go for the CTPA. But here you need not to wait for, if the well score is high, give the anticoagulants, okay, heparin, and then go for CTPA. Now, there's another scenario that the patient's coming to you with the suspicion of PE and he is hemodynamically unstable. Then you can actually do an echo, okay, to see the right heart. Okay, and if it's giving the features, okay, that are suggestive of PE, okay, you need to give the anticoagulant. If there's a massive PE, you're suspecting, you need to thrombolize the patient. You need to thrombolize the patient. The other thing you can do is ventilation perfusion scan, particularly in the pregnant ladies. Ventilation perfusion scan. But CTPA is gold standard. If they're going to ask you this important question that if you are suspecting this thing, okay, what is a definitive thing to do? That's CTPA. CTPA. Always choose the CTPA. So if it's a massive PE, okay, like patient is now becoming hypertensive, okay, it's massive PE, always go for thrombolysis or pulmonary embolectomy. It's small PE, you need to go for apixaban or rivaroxaban, that is DOX. Okay, or you can go for the low molecular weight heparin, but now you need to go for like DOX, that's if it's small PE. If it's recurrent PE, okay, because the DVD, that's going over there, the thrombus, so you need to put the, and particularly if there's a contraindication, if it's a recurrent or contraindications for anticoagulants, you need to go for inferior vena cava filter. So PE, very important, very important. 2-level PE well score, you need to calculate. So low risk, go for the D dimer, okay, and then CTPA. High risk, go for CTPA. Give anticoagulant and go for the heparin and go for the CTPA. If the patient is hemodynamically unstable, it's massive PE, okay, then go for thrombolysis, okay, or embolectomy. Recurrent PE or where you cannot give the anticoagulants, then you can put the inferior vena cava filter. Now comes the heart failure, congestive heart failure. Okay, so patient will be coming to you with the breathlessness, okay, ankle swelling, raised GVP, pleural effusion, cardiomegaly. Okay, it could be because of ischemia, valvular diseases, cardiomyopathies, alcohol, hypertension. What is the management of congestive heart failure? Okay, heart failure, the patient will be having the symptoms of the right heart failure as well as the left heart failure. Okay, you know that the right heart failure, okay, the patient present with raised JVP, edema, okay, low limb swelling, ascites, okay, congestive liver, and with left heart failure, okay, the patient presents with the pulmonary symptoms, breathlessness, and all that sort of stuff. So you give these patients, okay, if acutely some patient is presenting to you with the heart failure, okay, with the pulmonary edema, you give the furosemide. The pulmonary edema we're going to deal later on. Let's look at the heart failure. If the patient is having a heart failure, so you give the ACE inhibitors, and the AC inhibitors, okay, they decrease the preload as well as afterload, and they have role in the cardiac remodeling. AC inhibitors, okay, first thing, and the diuretics to these patients. The other thing, beta blockers, okay, and then if that's not working, you can go for spironolactone, and if still not, you can add digoxin. So the patient is having a heart failure, you start with the AC inhibitor, okay, plus diuretics, beta blockers, spironolactone, okay. Look at the potassium when you are like adding the spironolactone, and after that, if still not, you can consider the digoxin as well. So in X-ray, what you're gonna find out, that's like a bat wing appearance. You must have heard of that thing, bat wing appearance. Okay, so pleurophian capitalization of the vessels, curly B lines. So that's about the heart failure. Okay. Now comes the atrial myxoma. So it's a benign tumor of the atrium, okay, mostly in the left atrium it is, okay, and it's something like that. It is attached to the interatrial septum, okay. So here it is attached, and it is like freely moving, like a pedunculated mass. Sometimes it comes in the way of mitral valve as well. Then it causes the problem. So it's a benign tumor, okay, that is mostly in the left atrium, and I said how it is attached to the interatrial septum. So, yeah, it's written over there, okay. It causes the obstruction of the mitral valve, leading to loudest one, mid-diastolic murmur, dyspnea, syncope, a tumor polyp, sounds on auscultation. As I said earlier, that it's pedunculated, keeps on moving, freely moving, but that is attached to the interatrial septum on one side. So embolization and arrhythmias. So echo is the gold standard, and you remove it surgically. Okay. If you are confused, you can do the cardiac MRI to find out. If you are confused that whether it's a clot or it's a tumor, it's a cardiac MRI. You can go for the cardiac MRI. And the management is surgical removal. Oh, so if it dislodges on the left side, it can go down, can go up, even leading to stroke or acute limb ischemia. Embolectomy, when you remove it, okay, and the embolus. So it can cause embolization, go down and up, can obstruct the mitral valve, can lead to the arrhythmias. Okay, so here comes the pulmonary edema. Okay, that is an emergency. So there's a sudden onset of breathlessness, orthopnea, saturation is falling, you have fine end inspiratory creps on the lower zone. It could be, it's not only to the lower zone, depends on, okay, if it's a frank pulmonary edema, it could be up to the middle, okay. You can even listen to in the whole chest as well, okay, in severe life-threatening condition of a pulmonary edema. So fine end inspiratory creps. Fine end inspiratory creps. And tachycardia, the patient will be having a tachycardia, okay. So X-ray, you're going to find out interstitial and alveolar edema, okay. And echo you do, actually, that's going to give you some reason, because the patient is having a low ejection fraction, a patient's having some valvular pathology like the MR, they are more prone to like developing the pulmonary edema. So what you give the oxygen, okay, you give furosemide. Choose furosemide over here because this is a strong diuretic as compared to thiazide. Don't choose a thiazide over here in pulmonary edema, and you give the nitrates because they decrease the venous return to the heart. So oxygen, furosemide, and the nitrates in a patient with pulmonary edema. So in echocardiography shows an ejection fraction of less than 40. Okay, it's a heart failure. In the heart failure, what is the standard treatment? AC inhibitors, beta blockers, okay, diuretics. These are the things over there. In asthma, you cannot give the beta blocker. You need to avoid. And in acute heart failure, you also avoid the beta blocker. No, it's about the digoxin, what we call a digoxin. So digoxin toxicity, the patient comes with nausea, vomiting, confusion. This is important. Yellow halos. Okay, this is you need to remember. And the arrhythmias. Okay. Digoxin toxicity is when its level is greater than 1.5. Okay, you send the digoxin level, and if it's greater than 1.5 on the ECG, you're gonna find the reverse tick sign. Okay, reverse tick sign. This is like a reverse tick sign. Okay, and the management is that digipine. Now comes the statin. Okay, prescribing the statin to someone. Now, atorvastatin, rovastatin, pitvastatin, pravastatin. Okay, most commonly it's used in the UK, that is atorvastatin. Okay, so you give the statins either for the primary prevention or secondary prevention. Okay, primary prevention is that patient is not having any kind of event. Okay, cardiovascular event, but he's at the risk, so you are giving for the primary prevention. And if he's having, unfortunately, some event after that, if you are giving, that is for the secondary prevention. You don't want any of the other events to happen. Okay, don't want him to be in the same trouble again. So that's, you give it for the secondary prevention. In the primary prevention, 20 mg of atorvastatin is recommended. If here you're going to divide the population who is less than 84 and the patient who is 85 and above. In the patient who are 85 and above, okay, because of the age, they are vulnerable, okay, to any of the cardiovascular accident. So you give them primary prevention, atorvastatin 20 mg. But those who are 84 and less, okay, when you're going to consider statin for primary prevention, if the Q risk is greater than 10%, Q risk is actually a risk to calculate. Okay, that what are the chances of CV in this patient? So it calculates over the next 10 years, okay, what are the chances of having a CV in this patient? So if they are greater than 10, if there are the Q risk, okay, that is the 10 over the 10 year, okay, if the Q risk is greater than 10%, you need to give the primary prevention for atorvastatin, that is 20 mg. Okay, then there are the other categories, okay, like in the CKD, in familial hypercholesterolemia, and the type 1 diabetes, okay, you need to give the primary prevention. And those who are above 85 and above, you need to give atorvastatin 20 mg for primary prevention. So we have actually three things over here. Those who are 85 and above, you need to give them, even if they do not have anything else, okay, no diabetes, no hypertension. Those who are having CKD, familial hypercholesterolemia, and type 1 diabetes, okay, type 1 diabetes, actually, if it's greater than 10 years, okay, the patient is having, then you consider it, okay. At the CKD, you need to consider the primary prevention, okay, with the 20 mg of atorvastatin. For those who are having less than 84, okay, you need to calculate the Q risk. If it's greater than 10, you need to give for the primary prevention, atorvastatin. For the secondary prevention, those who are already having an event like STEMI, or those who are having the unstable angina, a stroke, or transient ischemic attack, or peripheral arterial disease, you need to give them 80 mg of